Hi, good morning, everyone. It's so nice to be here on such a beautiful Hawaii morning. Thank you, Dr. Masaki, for inviting me for this opportunity to speak amongst you all. Okay, I'm gonna just flip to this slide here. So this poor woman, she's at the tanning salon and she's learning what the prices are for different types of skin cancer. Okay, so I want to ask a few questions before I open this presentation. So I want you to raise your hand. So raise your hand if you enjoy being outside in the sun, maybe doing activities with kids or grandkids, going to the beach, the park, walking your dog. Okay, put your hands down. Okay, raise your hand if you've had a really bad sunburn in your life. Maybe you were red, you were peeling your skin, you had to put aloe vera. Okay, now raise your hand if you or someone you know has had a skin cancer before. So that's a lot of people. And that's why we're talking about this topic here. Okay, so this is what you need to know about skin cancer. I'm Dr. Mori. I'm a board certified dermatologist and a board certified fellowship trained Mohs micrographic surgeon or skin cancer surgeon. So I'm double board certified in this. All right, so a little bit about me. First of all, can you tell me where I am in the photo? So I'm born and raised in Hawaii in Windward, Oahu. Oh, I'm sorry. And I'm right here. Okay, this is a Siegel Waimanalo preschool in 1992. So think about where you were in 1992, and I was in preschool. And now I'm here and I'm trying to teach you guys about skin cancer, okay? Okay, so I was born and raised in Hawaii. I went to medical school at University of Pittsburgh School of Medicine, and then I did dermatology residency and Mohs micrographic surgery fellowship at University of Minnesota. What a blessing it is to be here and not there in in February or March. Oh my gosh, I'm so happy to be home. Now I'm in private practice at Physician Office Building 2, and I'm a clinical assistant faculty in dermatology. So I have no relevant financial disclosures for this talk. So why is this important? So we saw how many people raise their hand because they themselves or someone they know has had skin cancer before. Skin cancer is common, especially among older adults, but early detection can save lives. We like to take care of problems when they're very small and manageable and would require minimal downtime for treatment. If we let things advance and get bigger and bigger, then those procedures are often way more morbid. There's a lot more suffering involved for the patient and a lot longer healing time. You might also need other things like chemotherapy or radiation, sentinel lymph node biopsies. So we like to treat problems when they're still very small. So anyone can get skin cancer no matter your skin tone. Patients might think that this only happens to fair skinned people, but that's not true. I see a lot of people in my office who are multiracial, who have darker skin, who are of any race, ethnicity, or background. And so the bottom photo is Bob Marley, and he unfortunately passed away of melanoma on his toe. Okay. A lot of people don't know that. Does anyone know who the gentleman is on top? This picture was in 1980. Can you just shout out who it was? Jimmy Buffett. So he died recently of a rare skin cancer type called Merkel cell carcinoma. That is a particular skin cancer type that metastasizes, and that's why it can be so deadly. So this can affect basically anyone. So in order to teach you about skin cancer, we're going to run through some cases. So you're going to put yourself in my shoes as we run through three different cases of three different skin cancer types. Case number one, and by the way, these narratives are fictional. So I'm not outing any particular patient. These names are not real. Okay, so if you know a Mr. Fitzpatrick, it's not him. Okay, so Mr. Fitzpatrick, he's a 75-year-old Caucasian man, and he has a persistent scaly patch in the center of his forehead. It started about 3 months ago and it's slowly growing. At first, he thought it was eczema or psoriasis or dandruff, and he was using over-the-counter products like topical cortisone or dandruff shampoos as a face wash, but that spot wasn't going away. And it was also starting to bleed and scab. So this is Mr. Fitzpatrick in my office. So I'm a Mohs surgeon, a skin cancer surgeon. So these patients have already had a biopsy and are presenting for skin cancer surgery. So I'm kind of spilling the beans here, but what I've circled here, oh, I'm so sorry. What I've circled here, this is his skin cancer in the center of his forehead. So it looks pretty benign, okay? But this is an eczema patch that never goes away. So you should raise your suspicion when you see this in yourself or in a family member. This doesn't make sense. Why is this eczema spot not going away even though you're treating it appropriately, say with topical steroids? So Mr. Fitzpatrick has a history of extensive sun exposure at Kailua Beach when we still had Liberty House. Do you guys remember that? Liberty House? Okay. He usually burns and he rarely tans, and he has a history of 5 skin cancers removed with surgery in the last 10 years. This is one of the reasons why I like my job because it's outpatient surgery. And so the patient is awake and we can talk story. And sometimes certain patients have multiple skin cancers throughout the year, so I get to learn a lot about them. He's also a retired postman, and I mention that because that means his occupation involved him being out in the sun a lot. So not only are his hobbies out in the sun, but his occupation is out in the sun. So what is skin cancer? Skin cancer happens when abnormal skin cells grow and multiply uncontrollably. This is often due and most commonly due to genetic mutations caused by sun exposure. Depending on the type of skin cell that's involved with those mutations can cause different skin cancer types. So I've listed here the various skin cancer types as well as different genetic mutations that most commonly would lead to them. So that includes basal cell carcinoma, squamous cell carcinoma, melanoma, and even rarer types such as Merkel cell carcinoma, which is what Jimmy Buffett had. Skin cancer risk factors include sun exposure because the UV rays directly damage our cell nuclei in our skin. They cause things called thymidine dimers, which interferes with the cell's ability to replicate correctly. Fair skin is a risk factor because people with fair skin have less melanin. Their melanocytes make less melanin, which serve to protect those cell nuclei in our skin cells. So less melanin means less protection. Age is a risk factor because over time, genetic mutations will accumulate and can lead to skin cancer. The most critical mutations occur in childhood and early adulthood. So it's really important if you have kids or grandkids that the most critical time to protect their skin is now because they're going to be paying for it as they get older. Family history of skin cancer is a risk factor because certain families may have certain DNA that's more susceptible to getting these DNA mutations, but also families often have the same kind of social structures, the same exposures to the sun. You know, if my dad and my mom loved taking me to the beach, we all mostly got the same amount of sun exposure. So that's why family history is also important. And then history of sunburns and tanning beds. Tanning beds is at the same level as cigarette smoke in terms of carcinogenicity or cancer causing, according to the World Health Organization. So tanning beds are as bad as smoking in terms of cancer. So before we talk more about skin cancer, I wanted to review the basic layers of the skin. So the skin that we see with the naked eye is called the epidermis. And so that's this top level here, that's purple. So below that is pink, and that's dermis. So if you get a cut, the cut, if it penetrates the epidermis and goes into the dermis, then you're going to get a scar. And that's what causes a scar is trauma to the dermis, okay? So when the sun causes different mutations, say in the basement membrane, the basal cell layer of skin, basal cell carcinoma that can cause basal cell carcinoma. It takes about 2 weeks for the cells at the bottom level or basal cell layer of the skin to mature or migrate upwards into the stratum corneum, which is the top level of the skin. So that process takes about 2 weeks, and then it takes 2 weeks for the stratum corneum to be shed. So if a patient has, for instance, eczema, we're looking at a scaly rash. That means that they have a thickened stratum corneum, which is this basket weave-like stratum corneum that we see up top here. So we have basal cell skin cells. We also have keratinocytes, which are mature basal cell cells, and then we have melanocytes, which exist at the bottom level, and those create that brown pigment that helps protect our skin. So this is another zoomed in picture. So again, at the bottom is the basal cell layer of skin. And then as that migrates upward, these are called keratinocytes, and mutations in these cells lead to squamous cell carcinoma. This cell here that has a halo around it is a melanocyte. And a mutation in a cell like this, a melanocyte, will cause melanoma. So Mr. Fitzpatrick, his patch, his eczematous patch was biopsied, and this is what it looks like under the microscope. The epidermis is way too thick. This is not normal. Furthermore, in the dermis, there are these things called keratin pearls that are trying to form. Basically, the skin cancer is making what should be just at the top level of the skin. It's making it now in the dermis, and this means that the skin cancer is invading deeper into the tissue. Again, this is an example of those keratin pearls. So this squamous cell carcinoma is invading deeper into the dermis and the tissues and invading. So this is squamous cell carcinoma. It can be aggressive and may spread if untreated. It can spread to lymph nodes and other body organs. It often looks like a scaly red patch or a sore that won't heal. So this is another example of a squamous cell carcinoma. So you could see this and obviously tell that something is wrong here. This is a schematic diagram of squamous cell carcinoma showing the keratinocytes having a mutation, causing them to replicate, and then eventually what you can see with the naked eye is often an ulcer and hard raised edges, and that's because of the keratin accumulating. And then the skin cancer will penetrate deeper down into the dermis and further tissues. So then Mr. Fitzpatrick undergoes Mohs surgery, which is what I do full time, skin cancer surgery. So I'm going to talk a little bit about what that is. So Mohs surgery is a specialized surgical technique for removing skin cancer. It doesn't stand for anything. It's not an abbreviation or an acronym. It's just simply someone's namesake. So it was developed by Dr. Frederick Mohs in Wisconsin in the 1930s. And then over the years, the technique has been further refined and used for other skin cancer types. So Mohs surgery removes cancerous tissue layer by layer, and I examine these layers under the microscope to make sure the skin cancer has been completely removed. It ensures complete removal while preserving as much healthy tissue as possible because I try to use the minimum margin of healthy tissue around it in order to take it out, but then leave as much as we can. This is really important for spots. If you had like on the tip of your nose, you don't want to take a big whack out of your nose. You want to conserve as much tissue as you can. So Mohs surgery is often used for basal cell carcinoma and squamous cell carcinoma, but I have special training to use it in melanoma as well. I use a special histologic stain for identifying melanoma in the lab, and so that's how I can use it for melanoma. That's less common and requires more training. Mohs surgery is recommended for skin cancers with unclear borders, recurring or aggressive tumors. So I often get some of the most difficult cases that have been treated before and have come back where the treatment has failed for some reason. And cancers in cosmetically or functionally sensitive areas like the face or the hands, the underwear area, that kind of thing, where property is at a premium. So Mohs surgery basically on the day of the surgery, the patients will arrive, and then will depending, say for instance, it's the skin cancer's on their face. I'll lie them down. I'll mark the area. One of my nice nurses will numb the area, and then I'll cut out that skin cancer with a little bit of healthy tissue around it. And then I'm taking that tissue to my lab, and I'm looking at it under the microscope. The process of taking tissue and putting it on microscope slides involves flash freezing it and then cutting it in horizontal sections in very thin layers. We're talking like 4 micrometers thick. And then the histotechnologist has to put that tissue on microscope slides and then run it through a stainer. And then I'm looking at that microscope slide under the microscope and checking the edges to make sure that there's no skin cancer left. If I notice that there's some skin cancer left behind, say at the peripheral edge or at the deep edge of what I cut, then I know exactly where that is because I already drew a map of what I cut out. And then I take a red marker and then I indicate where that skin cancer remains. And then I bring the patient back to the exam room. We top off the numbing, and then I take a sliver more exactly where is needed. And then the process repeats in an iterative fashion until all skin cancer is gone. So we always tell patients we never know how long it's going to take to remove a skin cancer because some of these skin cancers are like icebergs. What you see at the top isn't all that lies beneath. And so we say, plan on being here at least all morning just in case, but oftentimes patients can get out sooner. In terms of taking care of the wound after it's been addressed, after the skin cancer has been removed, there's a couple options, including letting wounds heal naturally. That's called secondary intention. That means basically just letting Mother Nature heal the wound, and we don't use any stitches. When we can, we try to use stitches because that can speed the healing process. And then sometimes I have to do more extensive skin flap surgery or skin grafts when things are, very challenging. If the skin cancer is very big or in a very tricky area. So Mohs surgery is the gold standard treatment for many skin cancers. It has a 98 to 99% cure rate. It minimally removes healthy tissue, and then you get your results pretty immediately. It takes about an hour to an hour and a half for your results. It has a reduced recurrence risk because I'm looking at basically each cell under the microscope to make sure the skin cancer is all gone. So this is Mr. Fitzpatrick after the surgery. So he had, that eczema spot, was not what it seemed, and it went all the way basically to the bone. Okay, so this can be pretty shocking for people. Okay, so in order to repair this, this is tricky because, we don't want to just zip it closed and make him have a unibrow or deform his face, So it takes art. Now we're in the artistic phase. Okay. So you see here, I've drawn some markings. So in order to sew this up, I'm going to basically remove some skin from up top here, and I'm going to remove some skin from up top here and over here, and then I'm going to loosen the skin. We're going to cauterize, and then we're going to zip everything closed. You guys already saw the picture maybe in your handout, so it's kind of spoiled, but this is what it looks like now. Okay, so this means the patient is going to heal way, way faster, and it's going to look way, way better than having a huge dent in your forehead. Okay, so stitches on the face, usually I take them out in 1 week. Okay, so again, this is what it looked like, and then 1 week later, it looks like this. Okay, so he just has a very small scab just right here, and that's going to be gone in probably 3 days. Now he can go back in the pool. That was the most important thing for him. Okay, so he was really happy about that. Okay, the next case is Mr. Chamberlain. Okay, so I included this one because this patient's a little bit younger. Some people think, oh, skin cancer only happens to older people, and that's really not true. I've taken care of people who are 18 years old. They've been just blasted in the tanning booth, okay, since maybe they were 14 years old. Okay, so this is a younger gentleman. He has a 35-year-old, he's 35 years old and has a growing bump on the upper lip. At first, he thought it was a pimple, but it didn't really go away. And then it started getting wider and wider and wider. He noticed it about 3 years ago, but didn't really think anything of it. And it wasn't until recently that it started bleeding when he was shaving, and that's really what prompted him to get it checked out. He works as a commercial pilot. And I mention this because certain occupations are at higher risk for getting a lot of sun exposure, and being a pilot is one of them. Another thing you should know is are at increased risk of skin cancer, particularly melanoma, because of the chemicals that they're exposed to in the smoke. So recently, the dermatologist did a skin cancer screening among all the firefighters, and we did find some spots that they had. So that's something for you to know about too. So this is Mr. Chamberlain's spot. So he has, this pink plaque, we call it. It's somewhat raised here. And this is again a tricky area because it's right slammed in between the nose and the lip. So the stitches for this again require art. So Mr. Chamberlain has an extensive history of sun exposure as a former competitive paddler at Ka'ehi Lagoon. He sometimes burns, sometimes tans, and he isn't sure if there's a family history of skin cancer, but he says that he thinks his grandpa had some spots that were removed. So he has basal cell carcinoma. This is the most common cancer in all of the human species. So if you're thinking about all the different organs that could get cancer or leukemia, lymphoma, or skin cancer, basal cell is the number one type of cancer in all of humans. So you can know that I'm really busy, basically. Okay. So it often is a slow growing spot. It often appears as a shiny bump or a pink growth. So the skin cancer will start at the basement membrane or the basement level of the skin. So these basal cells got a mutation, say from the sun, and then began replicating out of control, and they basically grow up, and that causes this kind of dome-shaped pink papule to form. So this is what it looks like under the microscope. So basal cell carcinoma is often very purple when it's been processed in our lab. So the reason why it's purple is because these nuclei that are purple are way too big than they should. So that causes them to be purple. And then basal cell classically has this tumor retraction artifact whereby the tumor kind of retracts from the normal dermis, and that can help me locate it under the microscope. So this is what it looked like after we removed the skin cancer. So he's only 35 and now he has kind of a big hole in his upper lip. Okay. So in order again to do the stitches here, I have to think about different things. I don't want to pull his nose down or his lip up. He's 35 years old. We don't want to disfigure his face. So I have to basically make artful cuts kind of up his nose in this corner and then further down here on his lip, kind of in a frown line. And then we're going to pull skin to the midline, basically. So the next photo, we're going to show you the lip, by the way. If you inject enough numbing medicine in the lip, it really gets pretty big and kind of goofy looking. Okay. So I'm just warning you, this is not permanent. Okay. This will go away in a couple days, but this is what it looks like. Okay. So even though he has so much swelling, this is a absolute success because I can tell already that he's going to heal really nicely because we've hidden all the stitches in normal cosmetic lines in the face. So this is just him just 1 week thereafter, okay? So all the swelling is gone and he doesn't have a big hole in his upper lip. Okay? So this is a perfect result basically. Okay? In probably a year, no one will even know that he had a spot there. Okay. So in terms of skin cancer warning signs, I want to just tell you some. So skin cancer could be an open sore that just won't heal. If you're a healthy person, any cut or any wound that you get should heal eventually. Okay. If you have a sore that's been around for longer than a month and it's not budging, it's probably not just an innocent sore. It's probably something else like a skin cancer. And so you should go see a doctor for that. If you have a chronically irritated red patch, I've seen patients that they thought they had eczema or psoriasis and were treating it for years, But in fact, when you biopsy it, it was a skin cancer. It was a squamous cell skin cancer. So just be mindful. Things should really go away if they're being appropriately treated. You should not have a permanent wound or a scaly patch that doesn't go away. A shiny pink new bump could be a skin cancer. Basal cell likes to be a pink, translucent, or shiny papule. And then a new scar without any explanation. If you notice that there's a white scar on your face and it seems to be growing and you don't really think that you hit yourself or cut yourself, I think that you should probably get it treated or you should get it evaluated. It could be a skin cancer. And I'm not trying to scare you all, but these are all just things that I've seen. So you can have a heads up and maybe share them with your family too. So finally is Mr. Wilcox. So Mr. Wilcox is a 50-year-old Caucasian man with a dark spot on his scalp. His wife noticed it about 6 months ago. The spot has slowly widened and developed a darker area. It's not painful or itchy and it never bleeds. But his wife noticed that it was kind of getting a little bit wider and then there was a darker spot within it that was developing. So this is the spot here. You can't really see it, unfortunately, because of the glare from my overhead light. But that's the spot, and I've already drawn kind of a rim of healthy tissue around it. But this looks pretty benign, but you shouldn't have freckles that are this large, and they shouldn't have different colors within them too. So it does take kind of an astute eye, but his wife was very intelligent by having him get it evaluated. So Mr. Wilcox has an extensive history of sun exposure as an avid surfer. He usually burns and rarely tans, and he has no personal history of skin cancer, but he says his mother had skin cancer of some type back in the day. He runs a bed and breakfast on the Big Island. So again, I want to tell you about melanocytes. So no matter your skin color, we all have the same number of melanocytes, which are those pigment-making cells. That does not separate us. However, melanocytes, depending on your skin color, might produce more melanin, and that's what causes the different shades of brown, basically. So a browner person has melanocytes that are the same number, but they're maybe more prodigious in creating that pigment. The whole point of that pigment is to disperse it among the skin cells and then arrange it over the nuclei as an umbrella, a brown umbrella shielding those nuclei from sun damage. So this is a schematic of a melanocyte making melanin and then transporting it to these skin cells. And then the melanin here, these brown specks, then arrange themselves as an umbrella over the nuclei to protect the skin from the sun, which is coming this way. Okay, so melanoma is one of the most serious types of skin cancer. It can spread quickly if not caught early. So for instance, there was recently, just last week, a woman named Teddy Mellencamp. She's the daughter of, I think, John Mellencamp, the singer, and she unfortunately did a lot of tanning and had melanoma, and unfortunately, it metastasized to her brain now, and she just had brain surgery this past week. Okay, so that's not good. So it often appears as an unusual or changing mole or dark spot. Okay, so the melanoma would start at the basement layer of the skin. The melanocyte has accumulated enough genetic mutations and then starts to divide uncontrollably. It then grows up and down. So this is an invasive melanoma growing down into the tissues. So this is what melanoma looks like under the microscope. At the left is a standard hematoxylin eosin stain. It's very subtle, but these spots here, these are melanocytes. Again, they have kind of a white halo around them because in the tissue preparation in the lab, the melanocytes kind of retract from the normal epidermis. So these cells that have a halo around them are melanocytes. However, these melanocytes are way too high up in the skin. They should be way down here. So basically, the melanoma is causing them to divide so fast that they're actually traveling up into the skin. This is a different stain in my lab. It's called a MART1 stain, and this stains melanoma cells, basically. Okay, so basically you can see here that the melanoma cells are growing into the epidermis at the upper levels, and this phenomenon is called pagetoid scatter, and that's a sign of melanoma under the microscope. We can risk stratify melanoma by Breslow depth. That's one such measurement. I see some people nodding their heads because maybe they've heard of this before. So Breslow depth is the thickness of the melanoma measured under the microscope. So the pathologist is going to use a special ruler or calipers to measure how thick the melanoma is. And that's very important for telling how risky it is for spreading to other parts of the body. It's one of the most important prognostic factors for melanoma survival, and thicker Breslow depth is associated with a poor prognosis because that means that the melanoma has already grown deeper and deeper into the tissues and possibly has spread to lymph nodes or other parts of the body. So for Mr. Wilcox, he has a relatively early stage melanoma, which was good. His melanoma was only 0.4 millimeters thick, and that's relatively thin. Sometimes they're 2 millimeters or 4 millimeters, and that's really bad. His was 0.4 millimeter, and it didn't have ulceration either, which is another way to risk stratify. If it has ulceration, that's often a bad sign. Therefore, he has stage 1A melanoma, or the beginning stage of melanoma. After surgery with me, nothing further is needed except increased surveillance. Okay. He doesn't need chemotherapy or a lymph node biopsy or radiation or immune therapy. He should just follow up with his dermatologist regularly. So this is the melanoma after it's been removed. The scalp skin is very stiff. It's really hard to stitch together. The stitches often don't pull the skin very well because of how stiff it is. The skin on the scalp and on the top of your shins is some of the stiffest skin there is. And sometimes we can't use stitches. But then that would be not good because a wound like this, if you just let it heal naturally, it might take 4 to 6 weeks or longer to heal. So he wouldn't be able to do the things he enjoys, like going into the pool or anything like that. So I tried my darndest to get it closed, basically. So the skin further down on the scalp is a little bit more lax here, okay? So if I make cuts further down on the scalp, then I can loosen up enough and then pull it together. So does anyone have a Tesla? So basically he became a Tesla spokesperson. Okay. So after 2 weeks, we take out the stitches, and then he's not a Tesla spokesperson anymore. It all kind of went away. Okay. So it healed really, really nicely in 2 weeks' time. Okay. So I want to briefly review the ABCDEs of melanoma. So A is for asymmetry, or one half of the lesion is unlike the other half. This is a melanoma on the left dorsal foot. If you were to fold it in half this way, it would not be symmetric, and that's a bad sign. That's a sign of a melanoma. B is for border. So if it has a scalloped border, not a smooth border, but kind of a flower-shaped border, that's a bad sign too. So this kind of lighter brown area has more of a scalloped border. It also has different colors. C is for color. So there's dark brown and then a medium brown here. That's bad. Diameter is for basically anything larger than the width of a pencil eraser. So this one is way bigger than a pencil eraser. It's probably about maybe 1.2 centimeter, and a pencil eraser is about 5 millimeters wide. And then finally, E is for evolution, or has the spot been evolving over time? Has it changed? Is it getting bigger? Are there different colors that are forming over time? That can be a sign of melanoma. So what should you do if you notice a suspicious spot? So don't wait, get it checked by a doctor. Okay. It's often better to just have the peace of mind so you can just lay it to bed and not think about it anymore. Sometimes that might involve a skin biopsy, but oftentimes it's just better just to know what it was, even if you're going to have a small little cut, a small little scar. At least now you know what it is, and you can address it if it is a skin cancer. So a doctor will do a skin exam, and they might even use a special magnifying glass called the dermatoscope to look at the skin very closely under the magnifying glass. Treatment options include surgery, which is what I do, but then there are other treatments. Sometimes we can use different creams or radiation or chemotherapy or immune therapy. It all depends on how advanced that skin cancer is. And the key takeaway, again, is that early detection means the best chance for an easy treatment with as minimal downtime as possible. So to find a Hawaii dermatologist, there are about 60 board certified dermatologists in Hawaii. You can use this website, which is in your handout, and you can also scan this QR code with your telephone, and that's in your handout as well. So there's no such thing as a safe tan. I just want to end with this. A base tan does not protect your skin from UV damage. A base tan means that your skin has already been injured enough that those melanocytes are working overtime to protect your cell nuclei. So this would come up often on the mainland where people in Minnesota say, oh, I'm going to go to Mexico on a trip. So I don't want to get sunburned there. So I'm going to go to the tanning salon and get a base coat tan so that my skin is, hardened. That is the wrong idea. Okay. That means that you've already damaged your skin enough. And then I do want to mention that getting a tan releases endorphins in the body, and that makes you feel good. And so that's why some people are kind of addicted to being tan. They like the feeling it creates. It's almost like a runner's high. So just be mindful of that. That's one of the reasons why people like to get tan. So the take-home messages are to know your skin and self-check regularly. You can ask a family member to check areas that you can't see, like the top of your head or the back of your legs. Use sun protection every day and then see a doctor for anything unusual. Okay, Harold, you forgot to wear your sunscreen again, didn't you? Okay, so thank you very much. Thanks, Dr. Masaki, for the opportunity.
Thank you. Thank you, Wes. That was a really informative presentation. Thank you so much. And a very important topic, as you said, very common cancers. Do we have any questions from our audience? Oh,
Hi, thanks. Could you explain squamous cell cancer? You talked about basal and melanoma, but the in-between one.
So there are some in-between categories. So one category is actinic keratosis. That's a pre-malignant skin spot that is on its way perhaps to becoming a squamous cell carcinoma. So that's called actinic keratosis. There's also another category called squamous cell in situ, where the skin cancer has not penetrated further deeply into the dermis. And so we still want to treat those because over time they will invade into the dermis, but those are some other categories.
When I had radiation 29 years ago for breast cancer, nobody mentioned the fact that it increases your risk for basal cell until my daughter-in-law, who's a dermatologist, told me I needed to go every year. And sure enough, I did develop some, but they were taken care of early. So that's really important for folks who have radiation.
Absolutely. That's a good point.
If you have cancer and you're bald,
Yep.
you can see it, sort of. But if you have hair, how can you detect whether or not you have something wrong?
That's a good question. So you're probably going to need to have a family member or a doctor really inspect your scalp with kind of a fine-tooth comb or a Q-tip to look for it. Another way people realize they have skin cancer is they go to the hairdresser. And the hairdresser notice that they have a mole or something that's concerning. And there's actually been campaigns to educate hairdressers on how to look for skin cancer. So that is another way. Oftentimes it's just a pink scaly patch that you might think is dandruff, but dandruff is usually generalized. It's not localized to one particular area. So if you have a pink scaly patch that doesn't go away and it's just in one area, look for that. Or if you're washing your hair and there's one spot that always kind of tinges in pain, or you notice that there's a scab and you keep picking at it, then those can be signs of skin cancer. And then the other thing is wives save lives. So in Mr. Wilcox's case, his wife saved his life because she was paying attention. So I guess you just have to find someone who has an astute eye and can look at your scalp.
You said Bob Marley had cancer on his toe, big toe. Is it possible to have cancer under your fingernails or your toenails?
Absolutely. I have to I have to take out the toenail and I have to basically remove the upper surface of the toe. It's called his was called acral lentiginous melanoma. That's what he had. And probably maybe 15 times a year, I have to treat a skin cancer that is on the nail. Sometimes it's a wart that transformed into a squamous cell carcinoma. There are certain strains of HPV, the wart-causing virus, that lead to a propensity to making squamous cell carcinoma. I'm a really scary person, yeah?
So if you've had skin cancer, as I guess most of us have, like basal cell, you go back every 3 months or so regular, or what do you recommend as
Yeah.
get checked?
Yep, I would say if you had a melanoma, you should be seen quarterly for at least maybe 2 or 3 years, if not indefinitely. If you have a basal cell, maybe every 6 months to a year. Same thing with squamous cell. Often your dermatologist will kind of have a protocol for how often they should see you and what interval. Some patients who are on, like there's patients who are transplant patients. They have a transplanted liver or a lung, and they're taking medicine to help not reject their organ. That increases their risk of skin cancer. And so those patients might also be seen every 3 months.
I've gone through one of the surgeries, but I'm following with a dermatologist. When I go in every 6 months, she freezes a whole bunch of spots around my chest or my back.
Yeah.
Is that sufficient, or should I have a surgeon look at it?
Got it. So as long as they know what they're treating, so actinic keratosis, which is what I had mentioned earlier, those are those pre-skin cancers, those pre-malignant skin lesions that could possibly turn into squamous cell in the future. If they're treating actinic keratoses, and that's their diagnosis that they believe they're treating, then cryotherapy or the freeze gun is sufficient. They have to make sure that they're doing it strong enough though. Sometimes you can just do a light dusting and you're really not doing very much. You usually have to do 2 freeze-thaw cycles, and then the usual response is that the skin will blister up and the spot will fall off. If that's not really occurring, then that might not be an adequate treatment. But basically, these you can have things frozen, but if they're not quite going away, then they probably should be biopsied. It all depends on what the dermatologist or doctor thinks that they're treating.
Thank you.
Yeah.
When does melanoma become fatal?
It becomes fatal when it metastasizes to other organs and starts inhibiting their function. So, for instance, if it metastasizes to your brain and now you're having a stroke or seizures uncontrollably, then it can become deadly. Um, it all depends on how deep that melanoma was before it was discovered. So some patients, they may not have an awareness of this as a possibility and don't present for years and years, and the melanoma could be all the way down to the muscle, and then it would have spread already, and despite our best efforts with current treatments, it could metastasize and become incurable.
I have once heard, though, the depth of the melanoma is also indication of the danger of it. Is that true?
Absolutely. The Breslow depth is kind of directly correlated with how deadly it could be. Yeah. Yep. Can you repeat your question with the mic so everyone could hear?
if you're walking or running in the park, for instance, down in Kapiolani Park,
I think I've seen you there.
yes, I run every day. And am I still in the danger zone for melanoma at that time of day?
So I would say it's all about reducing or mitigating your risk and what you're doing as a healthy practice. So you're not going during the peak hours of 10 a.m. and 2 p.m.
Hmm.
The most important thing is adjusting your habits to mitigate that risk, but then also maybe using UV protecting clothing, because I would say in terms of how helpful things are, UV protective clothing is probably more effective than sunscreen. Because first of all, the barrier of putting on sunscreen, we're not all putting sunscreen like we should. Okay. So it's just simpler and more reliable to wear the right clothes, to wear a wide brimmed hat or a balaclava or something to protect your face and your ears, and wear long sleeves that with UV protective fabric. I've seen it all the time at Costco now. It's getting really popular, which is great. So those things, because people are not applying sunscreen enough, and then they're not reapplying either the sunscreen. So I think number one intervention would be wearing the right clothing.
A black wetsuit top.
Yeah, I think that would be okay. I'll look for it.
I run in it every day.
Okay. I think that would be okay.
Okay.
Yeah.
But I need something for my head, right?
Yeah. She needs to look at your head right now. Thank you.
Does radiation treatment and or gamma knife surgery, which is high radiation treatment,
Yep.
does that make you more susceptible to skin cancer?
That's a good question. I think someone over here mentioned that she had had a radiation treatment for breast cancer, right? So it really depends on the type of radiation. So gamma knife probably doesn't, because of the triangulation of how that works. It's very low pulses of radiation that then kind of intersect in a way that it's just targeting, for instance, a brain cancer or something like that. So that's probably less risky. But then, for instance, back in the day for acne, they used to use X-ray. They used to X-ray people's faces. I don't know if anyone's ever heard of that. They did X-ray people's faces, and then 40 years later, they're covered in skin cancer. So radiation can absolutely cause skin cancer, but gamma knife probably not so much.
Any more questions? And if you are asking a question, please speak straight into the mic.
What about mammograms, annual mammograms that women take,
That's a good question. I don't think you should worry about it. I haven't really heard of any correlation among that. I think maybe theoretically, but I have not heard of that before. And I'll be honest, I don't see a lot of skin cancer on the breast in general because it's usually protected. But I don't know anyone's lifestyle. Maybe it's not. I'm not sure.
I don't think we have too many of those types of beaches here in
Right.
Hawaii. Any last questions for Dr. Mori? Oh.
Thank you for your talk. I was surprised to see on the handout that we received that there are some cons to getting a screening, like an annual screening. And I just wondered if you could comment on that a little bit further, because I always thought that was something you should definitely do.
That's a good question. I think in general, it's a good thing. There are skin lesions called seborrheic keratoses, for instance. Those are kind of raised brown spots that people will get really worried about and think that they're skin cancers, and it can cause a lot of stress. So sometimes, a person might stress out about the wrong thing because they don't have the training of what to look for. So that could be one thing, is just kind of the added stress of having maybe too much you know too much for your own good, maybe kind of thing. And then that might lead to unnecessary biopsies too, depending on the physician if they're not sure what they're looking for. Yeah. Hold on.
As we get older, there's aches and pains, and obviously they suggest red light therapy or sometimes the stem cell patches. Do any of those have any correlation to skin cancer?
That's a good question. No, they don't. They don't. It's kind of a different wavelength of light that doesn't cause damage to the DNA in general. Good question, because I get asked about red light all the time. Yeah.
Just hold on for a second for the mic. Yeah, thank you.
How can you tell the difference between age spots and possible skin cancer? When I go and see my dermatologist, he says, "That's why you come and see me."
Yeah. That's probably why they went to school for like 13 years to be able to determine that. I would be looking for different colors within that age spot. If it's kind of all the same uniform color, if it has different colors within it, then that would be more concerning for melanoma.
Can you address? I've heard of artificial intelligence being used to diagnose stuff.
Where am I looking? I'm so
Oh,
sorry.
right.
Oh, okay. Okay.
Sorry. I've heard of artificial intelligence being used to diagnose images, maybe in breast cancer or something.
Yeah.
Is there a trend in skin cancer for that?
That's a really good question. So if you use a magnifying glass called a dermatoscope and you use it on 20,000 lesions and take photos of those lesions under the dermatoscope and upload them to a computer and tell the computer all the different diagnoses, eventually you will develop a program that can be utilized where a phone can take a picture of a spot zoomed up enough and tell with a certain degree of probability if it's cancer or not. And that technology is being developed. The danger of that is what if it's wrong though? It might be right 85, 90% of the time, but what happens to the 10 or 15% of patients where it gives you the wrong answer?
I think the same is true for radiology, for various microscopic lesions in many different diseases.
Yep.
There's a lot of testing of AI, but I think humans are still needed.
Yep.
Yes. Anyone else have any last minute questions? We have time for one or two more. No? Please join me in thanking Dr. Mori again.